Okay, good evening, everyone. Thank you so much for joining us today. We are going to look at case studies for systems review. So we are going to consider those systems that we studied on Saturday. We had the theory aspect of those systems. We'll take the practical aspect today. I hope all of you are ready with your case studies, just as discussed the other day. I'm going to present a few from the examples that are there in Goodman and Snyder textbook, and then we'll open the floor for contributions from participants. Dr. Jibril Samani, are you with us, either you or Hafiz?
Yes, sir.
Okay, is there anything you want to say, any comments you want to make before we start?
Not really.
Okay.
That after this, we still have the second part of the workshop, which will come up next Saturday, and then Wednesday. That will be the end for system review.
Yes. Okay. So that's all right. So thank you very much. So I'm going to be sharing the documents one after the other. As discussed last time, I will allow someone to unmute and read the case study and then ask the questions, and then we'll open the floor for members to answer the questions. So I'm not going to answer any question. This is something that's going to be participatory. Everyone is going to participate. Feel free, just say what you think the answers are, and then we'll now go to the answers and see if we are correct or if there is any different perspective to it. So I'm going to be sharing. I would have used the WPS because that will help me open as many as possible so that I don't have to keep sharing and unsharing, but I think I have it filled and I don't want to close it because I have many things that I have not saved. So I'm going to be opening them one after the other, share, and then I will close and share another one. We are going to start with pulmonary, with the pulmonary system. Okay, so if you can see the document I've just shared, can someone read what is on the screen, please? Please, can someone help read what is on the screen? Do I need to start calling people?
Let me read.
Okay, thank you.
Case example. I want to read now. Yeah.
Yes. Okay, go ahead, sir.
Case example 7.1. Bronchopulmonary pain from Goodman and Snyder. Differential diagnosis for physical therapy screening for referral. Fifth edition, page 291. Brief history. A 67-year-old woman with a known diagnosis of rheumatoid arthritis has been treated as needed in a physical therapy clinic for the last 8 years. She has reported occasional chest pain described as coming on suddenly, like a knife pushing from the inside out. It takes my breath away. She missed 2 days of treatment because of illness. And when she returned to the clinic, the physical therapy noticed that she had a newly developed cough and that rheumatoid arthritis was much worse. She said that she missed her appointment because she had the flu. I will read the question. Does this pain have signs and symptoms of a systematic disease? The second one, what are the red flags in this case? The third question, does this patient need a medical referral? Thank you.
Thank you very much, sir. That's good. So please, from the questions that we have, if you want to respond, you raise your virtual hand. I know some people, no matter how much prompt and motivation, so people will not want to come up and speak. You can send a message on the chat forum, but I would prefer that we speak directly so that at least we'll all interact instead of going through the chat forum to see things. So let's answer these 3 questions. Let's start with the first one. Does this patient have signs and symptoms of a systematic disease? Yes or no, and why? Please, we can raise our virtual hands so that I will call people to speak, and then those that post on the chat forum will wait until after the discussions before we read their responses on the chat forum. So we'll give more preference to the chat, those that are going to speak directly. It's very, very important for us to participate. Yes, wonderful. Yes, go ahead, sir.
Yeah, this patient has the symptoms of systematic disease. Okay. Because apart from the rheumatoid arthritis, she has chest pain, which of course later was thought to be flu. So,
okay. Okay, good. So the fact that there is flu shows signs of systematic disease, right? And what other thing did you mention? Is it the rheumatoid arthritis? You can say apart from the rheumatoid arthritis, the patient, chest pain, exactly. Yeah. So chest pain and a flu. So I'm not sure if the presence of chest pain alone will lead into a suspicion of a anyway, let me not begin to discuss it. Let's wait until after the answers, and then we'll go down and see what answers we have in the document. Any other any other response? Sincerely, I would like to see as many hands as possible. This is why I would say it's a practical thing. Wonderful. Yes, Dr. Ajibowe.
Good evening, Prof.
Good evening, ma.
Yes, apart from what has been reported, it can be clearly seen here that it's not just ordinary chest pain, because the way it is described, it says that is coming as a knife pushing from inside out.
Out, yes.
And it takes my breath away. Breathlessness is there. Discomfort is more than just ordinary chest pain.
Ordinary chest pain.
So with that, once you suspect a systemic issue, I don't want to be direct and say this condition. It's a systemic issue.
Okay, wonderful. Thank you very much. Now, can we, so please, anyone that speaks can put down their hand so that we'll be able to know if there are new hands that have been raised. Now, let's go to the second question. What are the red flags in this case? What are the red flags? I'll prefer, anyway, anyone can raise hands. I will not move on until I get answers so that I will force people to speak out. Or maybe what I will do at some point, I will start calling people. And if someone doesn't speak, we'll assume the person just joined and left, then there will be no certificate for that person. So I think if I don't see hands, I will start calling people. I'll just use what is on my system, those that are on top, and I'll continue to call until we get to the bottom. So even if you don't know the answer, just, aha, good. Dr. Ajo, please. Anyway, so you can answer this. You can answer this. Then after yours, I will now start to call people that are not raising hands. Yes, go ahead, ma. You need to unmute.
The red flags that I can observe here, there is a severe chest pain and there is breathlessness that is taking her breath away when she breathes. So that requires emergency.
Okay. So I think I want to also say that let's reflect back on what we discussed last time. Because last time we had very clear statements on what constitutes a red flag and what constitutes a yellow flag. Very important to remember that. I wanted to say, maybe I even said it at the end of last meeting, that it will be important for us to go back to those slides and study what's there, because that is what will determine the answers that we'll give in this case studies. So let me call Abdul Aziz Sofiat Bisola. Abdul Aziz. So please, the coordinators, the admin, Dr. Jibril, take note. Anyone we call and is not available, you take note that there is no certificate for that person. So please just unmute, say whatever it is, and we move on. If it's not correct, we correct it later. So Abdul Aziz Sophia Bisola.
Good evening, sir.
Yes, good evening.
Yes, sir. Well done, sir. The red flag there,
yes,
we can say chest pain.
Okay.
Breathlessness too.
Okay.
And also this rheumatoid arthritis, since it usually affects multi-organ, so we can actually refer the patient.
Okay.
Yes, sir.
Okay.
Apart from physiotherapy treatment, we can also refer the patient for co-managing.
Okay.
So that we might know whether the patient had other systemic affectations. Sir.
Okay. So that's good. Thank you very much. But let me remind you that from the case history, it says a known diagnosis of rheumatoid arthritis. And therefore, this is someone that already is receiving treatment for rheumatoid arthritis because it's known. And therefore, the referral might not be for the treatment of the rheumatoid arthritis. So it's important to take note of that. But, you know, sometimes you can ask patients, they got the diagnosis, but they are not under treatment. And therefore, you still need to refer them back. But if they are receiving treatment and they are seeing their physician, then you are not referring for the rheumatoid arthritis. You'll be referring for another underlying disease. So just to emphasize that. Thank you so much.
Sorry, sir. The issue of cough and the flu also.
Yes.
We don't treat flu in physiotherapy.
Exactly.
So
exactly.
It's another indication for referral.
Yes, the flu. Okay, so that's okay. So let's see. Yes, Dr. Achubwe. Go ahead, sir. And while you are responding, you can help answer the last question. Does this patient need a medical referral?
Yeah, thank you very much. I was trying to say that apart from the chest pain that the other person, respondent mentioned, another red flag there is the knife-like pushing pain that comes from the side of I want to believe, by at the end. He said the inside out that takes his breath away. That's a red flag. You know, it's a knife-like pushing pain that comes out, that is inside out from one side, that is inside out, that takes his breath away. He says it's a common sudden like knife pain, you know, that takes his breath away. I take that as a red flag.
A red flag. Okay.
Yeah, yes.
Wonderful.
Outside the chest pain, please.
Yes. Okay. Wonderful. Thank you very much, sir. Okubo Callistus.
Okay. Good evening, sir.
Good evening.
Okay. I think the red flags here should be the cough, and when she said she had missed her appointment because she had a flu. Most times the common symptoms that people presume to be flu will include some constitutional symptoms like fever, like body weaknesses, body pains.
Okay.
So those constitutional symptoms would red flag because might not really have a flu, and she's presuming that she has it.
Okay. Good. Thank you. Abiodun Dawood. Abiodun Dawood, you need to unmute. Okay, so while you are unmuting, let me just quickly read some of the comments online. Say knife-like pain is a likely red flag. Okay, that has been mentioned too. Good evening. Say the red flag here is the pain, the breathlessness. Yes, we have had that too. Cough and flu as red flag. Good. Okay. Cough and chest pain like a cut indicates red flag. The patient definitely needs a referral. Okay, so that's answering the last question. The patient needs medical referral. Yes, Mama Olada Potayo. Yes, man, you need to unmute. Hafiz or Dr. Samani, I hope the system is not structured that we need to ask people to unmute. I think the system is structured that everyone can just unmute and speak, right?
Yes, everyone can unmute himself.
Okay, okay. Mama, you need to unmute. I can see your hands up. Okay, so maybe let me go ahead and continue reading. The patient needs medical referral. Yes, the patient should be referred for further investigation and management. The patient needs referral because she's showing symptoms of infection and will benefit from antibiotics. Chest pain coming in suddenly. Yes, okay.
Yes. Yeah,
yes,
I was saying the patient missed 2 days of treatment, came back, worse off with the rheumatoid arthritis. So definitely she should go back to the doctor that probably sent her for physiotherapy.
Yes, ma'am. Okay. So that's wonderful. Thank you. I think we have taken all the comments either on the platform or on the message meeting chat. The breath can be called dyspnea. Okay, so let's now look at the answer. Can someone give the answer? Read out the answer, please.
I can read the answer. Good evening, sir.
Okay, good evening. Thank you. Go ahead.
Good evening, Prof.
Yes, good evening.
Further questioning to elicit the potential development of chest pain on inspiration, the presence of ongoing fever and chill in breathing pattern is recommended. Positive findings beyond the
we can't hear you again, ma.
Beyond the reasonable duration of influenza symptoms, shortness of breath. Can everyone hear me?
Yes, we can hear you. Go ahead. We can hear you.
Okay. Positive findings beyond the reasonable duration of influenza, 7 to 10 days, or an increase in pulmonary symptoms, shortness of breath, hacking cough, hemoptysis, wheezing, or other changes in breathing pattern raise a red flag, including the need for medical referral. This clinical case points out the clients currently undergoing physical therapy for a known musculoskeletal problem may be describing signs and symptoms of systematic disease.
Okay. So now from what we have here, do you think this answer agrees with what we have discussed earlier?
Perfectly, sir.
Okay.
Yes.
Okay.
Yes.
I think the only issue is that it's not a straightforward red flag issue that needs referral. Because when you have issues that need referral, straight away you just go for the referral. But what this response is saying, there is need for further questioning. It is the further questioning that will reveal more information that will determine whether the case is a red flag or not, and whether it needs referral or not. Do you see that in this answer? Look at the answer. Further questioning to elicit the potential development of chest pain on inspiration. So you are now asking the patient, inspire. When you inspire, when you take in a deep breath, what happens to the pain? The presence of ongoing fever and chills. So you say flu. Just asking, just saying there is a flu. Is there a fever? Because someone can just be sneezing and coughing and things like that. Is there fever? Is there chills? Remember when last we looked at this, it was about the fever and the chills, not the flu. But we know the flu usually comes with them. So, but are they there? If there is no fever, there is no chills, someone is just saying I have flu because they have running nose or whatever. Is that enough just to say that it's a red flag and therefore there is a systemic issue? Send or refer. It's a red flag. So these are issues that we need to question. What causes the chest pain? On inspiration, does it increase or not? The presence of ongoing fever and chills. You said you have flu. Is there any fever? You now take the temperature. Is the patient shivering and shaking? Yes or no? And the changes in breathing pattern. What's the breathing pattern of the patient? So these are the things that put together in addition to what the patient case report has reported that is going to now further give information as to whether it's a red flag or not. Then the positive findings beyond the reasonable duration of influenza. So is it beyond that 7 to 10 days? We asked the patient, since when have you been having this flu? Or an increase in pulmonary symptoms, that the shortness of breath keep increasing. We didn't get information about cough. Whenever there's hemoptysis, remember we mentioned that. Whenever it's there is a problem of systemic nature, wheezing or other changes in breathing pattern. So it's all this or part of this that will now raise a red flag. Please just give me a second. Let me change position. They took a flight and there is a generator very close to me. Let me just move to another location. Okay, they just off it. If it comes back, I will have to leave again. So I think, is there anyone that has any different view from what I just mentioned? Okay. So okay, let me ask who is next on the Abisola, Bemisola.
Hello, Prof, before you continue, sir.
Yes, okay, go ahead.
Yes, sir. The aspect of this changing in breathing pattern, the aspect of that sharp knife-like something, is it not enough to raise?
It's not enough.
Okay,
it's not enough, because if you go back to the slides we studied last time, you'll see that a red flag comes with a combination of things, a number of things. It's not just one thing that usually indicates that there's a red flag. Remember, this kind of things, pain, that type of pain that we mentioned, it can be a yellow flag because we don't know the source of that pain. It's possible that you can have a pain that is not systemic. It's not an organic pathology that causes it, but you have that type of pain. The different type of pains that we have, it can come from different sources. So the type of pain alone cannot be a red flag. You have to have symptoms that are systemic in nature. So what is they said, whenever you have fever and chills, there is an organic pathology. So for example, that's something. If you ask about the type of the pain, changes with positioning, changes with inspiration, changes with activities, and things like that, we need more information. So the patient just reporting that there is pain, and this is the type of pain, does not directly indicate. You can suspect that there is an organic pathology, that there's a red flag. Then you now ask further questions. And that is what we are talking about. If you just see that and you refer to a medical doctor, he will now ask those further questions. And then he will now realize that there is no organic pathology. And then he will now feel, that is why I said, don't send patients to me. Send them to someone that can be able to ask those further questions. Because it's the further questions that he wouldn't want to ask. He just wants a situation in which there is something substantial to indicate that there is an organic pathology, so that when the case goes to them, they know they only need to now initiate action on their own part, not to now further verify and send it back. So this case, from what we saw up, from the answer that we have here, is a yellow flag. It requires further questioning, because when you have a red flag, you are not having any further questioning. It's an immediate case, it's an emergency case. You just quickly refer the patient. You are not doing further questioning. So further questioning comes with a yellow flag. You now want to confirm if there's a red flag. And I want to refer you back to those slides that we read, because if you look at them, you'll see some of these things that we have, as they said, further questioning, are the things that we have in there indicating a red flag, not a yellow flag. Thank you. That's a very good one. So I'm going to share another document. Okay, so can someone help us read? I think we don't need, let's start from the brief history. This is a case about pneumonia. So it's also pulmonary. Can someone help read?
Yeah. A 42-year-old man came to an outpatient physical therapy clinic with complaints of painful swollen knees. Symptoms were first observed 10 days ago, and left knee was reportedly worse than the right. Stiffness was reported in the morning, on rising, with pain increasing in the day as the day progressed. As a non-smoker, the man reported his general health as good and noted that he had sprained his left ankle 2 months before the onset of knee pain. The knee joints were not tender, warm, or red. Observable and palpable boggy fluid could be demonstrated in the popliteal spaces bilaterally. There was no sign of effusion when viewed anteriorly, and the test for a wave of fluid was negative. All special tests for the hip and knee were negative, with full active and passive range of motion present. There was no known history of Baker's cyst, that's herniation of the synovial tissue through a weakening in the posterior capsule wall, reported. There were no palpable myalgias of the lower leg musculature and no trigger points present. The left ankle demonstrated some residual stiffness with a mild loss of plantar flexion. Joint accessory motions were consistent with a grade 1 lateral ankle sprain. Standing posture was unremarkable for possible contributing alignment problems. The clinical presentation of this client was puzzling to the evaluating therapist. A brief screening for possible systemic origin of symptoms elicited no red flag symptoms or history. Ongoing evaluation continued as treatment for both knees and the left ankles was initiated. After 3 weeks, there were no changes in the clinical presentation of the knees. At that time, the client developed a noticeable productive cough with greenish yellow sputum, but no other reported symptoms. Vital signs, including temperature, were unremarkable. Now the questions are, does this patient have signs and symptoms of a systemic disease? What are the red flags in this case? And does this patient need a medical referral?
Good.
Thank
so
you.
This is similar. Thank you very much. Thanks a lot. The questions are similar to the ones asked in the last case study. Now, can we answer the questions? Does this patient have signs and symptoms of systemic disease? I will be calling out people that have not spoken before, as listed. Abiodun Dawood, I think you raised your hand earlier. Try to speak now, because if not, we'll now note you as being absent. Abiodun Dawood. Okay, so please send a message on the chat forum. If not, we are going to count you as absent. Abubakar Abdullahi. Abubakar Abdullahi, on mute and answer one of the questions. Yes, go ahead.
Yes, sir. I think from the case study, if you look closely towards the end, where it says the patient has noticeable productive cough with greenish/yellow sputum, I think that is clearly indicative of a systemic involvement, sir.
Okay, so that's okay. That's noted. Thank you. Let's have Ademola Lajide. You can answer the next question. What are the red flags in the case? Ademola, unmute and speak. Or send a message through the chat forum if you can't unmute. Adenekon Kayode. Please, Hafiz, take note. At least let's give one chance. Next time we call Ademola, if we don't get a response twice, then we'll count Ademola as absent. Kayode, Adenekon Kayode. It's going to take us a very long time before we do 3 or 4 case studies. But sincerely, if we don't participate, our level of understanding of the whole thing will be very low. That's the purpose of having this separate class, to only do things practically. Okay, please take note of Adenekon also. Okay. Okay, let's take Anozie.
Yeah, good evening, Prof. Good evening, everyone. Yeah, I just want to make a comment on the symptom that was already mentioned here. People have commented on the noticeable productive cough with greenish yellow sputum. I think we also need to probe further because I want to find out this cough, productive cough, is it just a one-off thing? And I have some people's baseline color of their sputum can still be yellowish. It doesn't always, greenish or yellowish sputum does not always, it's not always indicative of an underlying infection. I would also want to find out if there are accompanying odd signs like there is feverish. I want to also check the pattern of that cough. Is the cough is it nocturnal or does it happen in the day? I want to also find out the triggers for the cough. Is it on exposure to some allergens? I want on exposure to cough or this. I want to find out about the environmental factors around that cough. So in as much as we see a cough and we say, oh, this is definitely from the lower respiratory tract, there may be an infection that, but sometimes it may not necessarily be that we are thinking towards an infection. I just want to just make that comment before I explore other areas. Thank you, sir.
Thank you very much. That's a good one. Sanity Journey.
Okay, sir. Thank you. My own is regarding the red flags. I think, sir, the fact that after 3 weeks there are no changes in the clinical presentation of the knees should raise concern. So I think the patient need to be reviewed further, and if possible, refer him for medical investigations. That might be. Thank you, sir.
Thank you. Yes, so Adenekon and Ademola, please make sure you respond to at least one question. It might not be on this case study. Even if it is on another one, I can see your post that you are present, but you can't unmute or something like that. So please try as much as possible to respond to at least a question. I will be monitoring to see your response in the later case that we are going to look at. Dr. Ajiboye.
In addition to all that has been said, I want to look at another aspect as related to even the physical therapist.
Okay.
Can we assume that the physical therapist did not do the thorough system review before she started the treatment? Maybe if a detailed assessment had been done, maybe she could have picked up some of these things that is now manifesting after a few days of intervention. So that's another aspect that I want us to look at.
Okay.
The importance of system review again, because a patient came in with knee problem or ankle problem does not exclude us from knowing whether there are other underlying pathology that has not manifested.
Okay. Yes, I think Mr. Anozie also mentioned. Okay, sorry, are you still speaking?
No, this is Dr. Taiwo.
Okay, yes, ma. Go ahead, ma.
I was going to say the issue of history taken is very germane. If history is not thoroughly elicited, then things can be missed.
Okay.
So the issue of the importance of history taking and thorough examination, as Dr. Ajiboye mentioned, needs to be really emphasized. That these are very, very important for us to be able to go ahead and get thorough results from our screening.
Yes. Okay. Thank you very much, ma. I just want to point us to a statement towards the end. It says after 3 weeks, there were no changes in the clinical presentation of the knees. Then it says at that time, meaning it's possible there was a thorough review, even asking about the chest, and possibly nothing was there. Possibly it was at that time the client developed a noticeable productive cough. So possibly what Dr. Ajiboye is saying is that if there was a thorough assessment, signs that this cough would have presented itself at a later time would have been seen. Maybe that also is possible, because sometimes you can have some reasons to believe that something has started, but some of the symptoms have not appeared. But the fact that this says it was after that 3 weeks that the cough was developed or was noticed possibly might mean that there could have been a thorough assessment, but this came later after the assessments, initial assessment of the knee problem was done. But it's also very possible what Dr. Ajiboye said is what happened, that there was no thorough assessment initially to be able to indicate the presence of any chest problem. But whatever the case, we are going to see what the answers are. So what do we think? Are we to refer this case, or are we to do further assessments? I think some people have mentioned that we should do further assessments. I saw some posts on the chat forum. Eugene, you have not been called, so relax and just wait. You will be called very soon. Trying to, okay, further investigation, yes. Kenya, Harry said, I think further investigation should be done in form of X-ray. I have the presentations were presented to the physiotherapist. It's either he or she engages in senior colleague for further input, or he refers the case, okay? In addition to all this said, I think the greenish colored sputum should be investigated, though may not be an indication for anything serious. Then the pattern of cough is should be noted as well. Okay, so let's look at the answer. Can someone help us read the answer?
Good evening, everyone. Okay.
Good evening.
Given the unusual, should I stop?
Yes, no, go ahead. Go ahead, Ijoma.
Given the unusual clinical presentation, lack of progress with treatment, and development of a productive cough, this client was referred to his family physicians for a medical evaluation. A one-page letter outlining the therapy's findings and treatment protocols was sent with the client. A medical diagnosis of pneumonia was established. The physician noted that although the clinical presentation was unusual, knee involvement can occur with pneumonia. The pathophysiologic mechanism for this is unknown.
Okay, so what will we say about this case? Is there a red flag? Is it a case for immediate referral from what we have in the answer here?
They've mentioned pneumonia already, so.
Yes, no, what I mean is that from what we have as a case, you know, the last question was, does this patient need a medical referral? And we didn't answer that because we saw some posts that said we should do further investigations. But saying further investigations need to be done. The question is by who? Is it by the physiotherapist?
The doctor.
Or is it referred by the doctor? Okay. So in that case, this is a red flag from this answer.
Yes.
And one of the things that makes it to have systemic nature as a problem is the productive cough, just like a few participants have noted. So lack of progress with treatment, because this is a condition that is expected that when you treat, the patient's symptoms will be relieved. That's the expectation in that kind of situation and the diagnosis that the physiotherapist thought it was. Then most importantly is the issue of productive cough. But remember, someone mentioned there is need to further ask about environmental issues and things like that. But since there's a productive cough that is green, it indicates an infection. And therefore, those environmental questions are things that the medical doctor can ask around that. Having a productive cough that is green. If it is not green, you don't have to refer immediately because it might not be an infection. It might be an irritation in the system that your postural drainage will help. And that is where we'll be talking of the possibility of either keeping the patient or referring or keep and refer at the same time. So that is really very good. At least we also have an information that when you have pneumonia, you can have knee involvement. That also is an information that was gotten from the medical doctor. And very importantly, to note that this case was a case that was not with a medical doctor. This was a case that was with a physiotherapist. The fact that the physiotherapist was able to identify cough and that is productive and referred was what helped the medical doctor to have a medical diagnosis of pneumonia. And that is what is expected of us, to be able to identify the suspicion of an organic pathology. We refer so that the diagnosis will be done by the medical doctor or physician, so that treatment will be given for the organic pathology. This is a very good one. We have two hands, Dr. Fine and one called James. You can go ahead and speak if you want to speak to this, or maybe if it's the old hand, you drop it.
All right, thank you very much.
Okay.
It's a new hand. I wanted to mention it, just that I didn't have the opportunity, or I didn't consider it for me to say anything until now, because you didn't mention it.
Yes.
The buggy fluid, at the posterior knee, posterior part of the knee bilaterally, for me, is suggestive of red flag.
Okay.
Because if it is unilateral swelling, that wouldn't have been a problem, but it was bilateral, and that is why in the findings or write-up there, the doctors, stated that pneumonia has a link or association with swelling of the knee joints. So that's what I just want to point out. Thanks.
Okay, wanted to add. Okay, thank you very much. James Wanko.
Okay, good evening, Prof. I don't know if you can hear me.
Yes, I can hear you. Go ahead.
Yeah, I don't know if it's a suggestion or a contribution, but the case, I suggested that we should get a CT done because my friend had such a case. His clinical presentation was not anything about production of sputum or coughing, but his was about swelling of the knee. So after some treatment, there was no improvement. There was no referral for CT, and it ended up being that he had CA of the knee, and he was amputated like 2 weeks ago.
Okay.
Thank you.
Thank you very much. Okay. Looking for radiological investigations or medical laboratory investigations is when we suspect a physical diagnosis. So we suspect that there is a movement impairment, but we want to confirm it. Then we can ask for it. But when we suspect an organic pathology, instead of us requesting for any radiological investigations, in as much as it constitutes a red flag, we refer and allow to ask for the radiological investigations to confirm the organic pathology. So I agree with you that we can request for radiological investigations or laboratory tests, but that is if the suspicion is for a physical diagnosis. We go ahead, we ask for it so that we can be able to confirm that physical diagnosis. But if the suspicion is that of medical diagnosis or organic pathology, then let's not do the investigation just to further suspect. In as much as a red flag situation the picture is there, then we will refer. Let them take it away. So as I've always said, the key is going back to those slides and looking at what constitutes a red flag and what constitutes a yellow flag. In a yellow flag, you have to do more inquiries. But with a red flag, you don't need more inquiries. You don't need any laboratory test or radiological investigations. The moment a red flag is established, we refer. Yes, thank you so much to all those that have contributed. Can someone read this third case study or case example?
Case example
7.3 Neurological deficits in a smoker. From Goodman and Sidner, differential diagnosis for physical therapy, screening for referral. Brief history. A 66-year-old man was referred by his primary care physician to physical therapy for weakness in the lower extremities. He also reported dystasia, pain with touch, in both legs from the knee down. The symptoms had been present for about 1 month before he saw his doctor. At the time of his physical therapy evaluation, symptoms had been present for almost 2 months. Client was delayed getting in to see a therapist due to his scheduling conflicts. The client was a social worker who had never been married but had 2 children out of wedlock, had a history of chronic alcohol use, and reported a 60-year history of tobacco use. Pack years is equal to number of packs per day times number of years. In this case, the client has smoked 2 packs a day for the last 30 years. Past medical history was negative for any previous significant injuries, illnesses, or hospitalizations. Both parents were killed in a car accident when the client was a child. Any other family history was unknown for the parents and unremarkable for the siblings. Clinical examination revealed mild weakness in the distal muscle groups of the lower extremities. Left was weaker than right. Altered sensation was circumferential and included both lower legs equally. Tests for Clonus and Babinski were negative. Deep tendon reflexes were equal bilaterally and within normal limits. Other neurological screening tests were negative. There were no constitutional signs or symptoms reported or observed. A program of screening and conditioning was started based on the physician's referral, requesting strength training and clinical findings of muscular weaknesses. In the first 2 weeks of treatment, the client's weakness increased and he developed bilateral foot drop. He started reporting episodes of dropping anything he lifted over 2 pounds. A quick screening examination showed bilateral weakness developing in the hands and wrists, as well as the feet and ankles. Questions. What are the red flags in this case? Are there any other screening tests that can or should be done? Does this patient have signs and symptoms of a systemic disease? Does this patient need a medical referral?
Good. Thank you very much. Can we have responses? I'll prefer people that have not spoken earlier, but it's okay also to have those that have spoken. Let me see hands. If not, I will now begin to ask, call people directly.
Smoker.
Okay. Is someone trying to speak? Yes. ST Bayawa.
Good evening, sir. For the fact that he's a smoker for that long period is a red flag. Thank you, sir. Hello.
Hello. Yes, sorry, a call came in and cut the line off. Someone started to speak. Can the person continue?
Yes, sir. For the fact that he has that 60 years, 60 pack year, it's a very serious red flag, sir.
Okay. Okay. So, okay. So let's keep that in view and see what the answers will say, whether it's a red flag or yellow flag. But keep it in view. Let's see. Peter.
Good evening, sir.
Yes, good evening.
This patient has been a chronic smoker and also alcohol use. I think it's a yellow flag.
Okay.
And the progressive weakness of the bilateral upper limb involvement and the lower limb, that's a thing that we have to do further investigation.
Okay, good. Okay. Are you done?
Yes, sir.
Okay, thank you. Michael Ezeki. Yes, Michael, we are listening.
Okay, good evening, sir.
Good evening.
So red flags that I noticed here. Well, I wouldn't necessarily call them a red flags. I just think that more investigations should be done, especially concerning the progressive weakness that is developing, spreading into the hands and wrists. And the fact that the weakness even seems to be getting worse in the lower limbs also. Looking at this alone, I'm just looking at something that is spreading through the spinal cord. But I don't want to jump into conclusions, but I feel it's something that requires more investigations. It's even looking at it, if I can even go further, even saying, okay, answering this second question, asking about any further screening tests that should be done. There's a lot of lab tests that should be done. A lot of, there's some radiographic investigations also that need to be done. But answering the first question about the red flags, I just feel that more investigations should be done, just as the previous.
Thank you very much, Michael. Anozie.
Yeah, thank you very much. I just want to add to the comments that has been made. I want to just make a suggestion because I don't know from the screen I'm reading it. Before the questions are already run down, before we digest it, we're already answering the questions. So we may not have forgotten the flow of everything, except if we can do a screen grab, then we'll look through again and we'll see something like that. It helps us to, yeah.
Let me do this.
But from what I wanted to add was that if the patient is a chronic smoker, and those are just the things that will give us a guide to ask more questions, then I'm asking about the alcohol use. We know that, of course, alcohol is a CNS depressant. So I'm thinking prolonged use of alcohol, what effect does it have on the central nervous system? Could it also be responsible for what is happening? Because I'm aware of what they call the Wernicke-Korsakoff syndrome, which is usually in people who have chronic alcohol use. Then with the chronic smoking, I was thinking towards, is this patient also developing, is at risk of the action? Then the progressive weakness of the limbs, it seems like it's an ascending weakness. So I'm already thinking of ascending polyneuropathy, which this patient would definitely require some other laboratory, not just radiological investigations that we need to do. Because I'm thinking of, I don't know whether there was any history of trauma, but I will be thinking both laboratory and radiological investigation. Then, so this patient still needs further detailed history taken more than further examinations there. So I wouldn't call it red flags per se. I'm seeing a lot of yellow flags here.
Yellow flag. Okay.
Yes.
Wonderful. Yeah. Okay. Let me not give clues. Let me allow the discussions to continue. Thank you. Felix. Those that have spoken can put down their hands. Thank you. Good evening. Yes. Thank you, Mr.
Yes, thanks.
Go ahead. Yes.
Thank you so much for the opportunity. Well, starting from the last few lines, so we could see that there's a progressive neurological problem, with the client, because initially we were told that the pain and the weakness was from the knee downward. Now we can see a progressive upward, of neurological deterioration of the patient, shows clearly a systemic problem, happening. So which we need further investigations and inquiries, into other areas of his well-being. Then also the clients, being an alcoholic person as well as a smoker over a long period of time, but have also exposed him to a lot of health conditions that might also hamper his well-being. Then being a smoker and also an alcoholic shows a sort of yellow flag. It's not a red flag per se, because those are just risk factor. So you can't say they are red flag. They are yellow flag that you need to take note of, that can further predispose the patient to more problem later on with this health, and which we are also seeing now coming forth gradually as the day go by. Because after a month, 2 months, 3 months, we can see a progressive deterioration in his health, based on his past lifestyle. That's now manifesting greatly concerning his health. Thank you so much, sir.
Thank you. Thanks a lot. Sani Tijani.
Okay, sir. Thank you.
Those that have spoken, put down your hands. Michael, Felix, please put down your virtual hands. Yes, go ahead, Sani.
Okay. Okay, thank you, sir. Sir, my own is regarding the fact that the patient has been experiencing symptoms for 1 month before seeing the doctor, and 2 months symptoms before seeing the physical therapist, and the fact that he is a chronic alcohol consumer and chronic smoker. I think the fact that he is having progressive weakness might lead suspicion of kidney involvement, because he is chronic alcohol consumer, and EUCR is an investigation that can reveal the level of creatinine, which can be associated with the weakness he is experiencing. So I think more investigations, specifically laboratory investigations like EUCR, electrolyte, urea creatinine, will help give us more information about the condition. Thank you, sir.
Okay, thank you very much. Yes, Adiolu Babatunde.
Thank you, sir. And well, from my own point of view, I agree with what most of the other speakers have said. Well, I think we also need to consider the patient's age. He's 66 years. Someone that is above 50 or 60 years having such symptoms is another red flag from my own point of view anyway. Thank you.
Okay, thank you very much. Kennedy.
Good evening, sir. Thank you very much. So I want to point out the pain when touched, that's the dysesthesia. And we all know that this dysesthesia can be a symptom of either a neurological disease or autoimmune disease. Also, from the passage, it was also pointed out that the patient had progressive weakness, which is also another symptom of an autoimmune disease. So I think it's a red flag, and during further investigation, maybe the patient should be tested for maybe an autoimmune disease. So thank you.
Good. Thank you very much. Saidu Haruna. Saidu Haruna, are you there? Okay, Mubarak Amin. Okay, Jamda, Uriah Jamda.
Good evening, Prof.
Yes, good evening.
Thank you for the opportunity given to us. Thank you so much. What I want to point out here is he had 2 children out of wedlock and history of chronic alcohol consumption. So for me, I would like to screen the person for HIV.
Okay. So thank you for all the comments. Let's now look at let's look at very quickly the answers to the questions. Now, number 1, the question was, what are the red flags? So age over 50 years, significant smoking history, alcohol use, bilateral symptoms, and those that are on the chat forum. I didn't read out because you are speaking really similar to, you are posting things that were similar to what was being said on the platform, because I saw issues like yellow flags due to the alcohol and smoking and the progressive weakness of the extremities. So I think these things put together, remember I said red flags usually come with a combination of risk factors and a few symptoms. But whenever you have risk factors alone, then you are thinking more towards a yellow flag. So in this case, from what these answers are showing, indicating, we have age over 50 years, which is a yellow flag, sorry, a risk factor. Significant smoking history is a risk factor. Alcohol use is a risk factor. But then you have symptoms, bilateral symptoms, hands and feet. And each of these, I think someone has mentioned one of these things that we are discussing, possibly separately or in combination, but I don't think there's anyone that has mentioned all these 5 at the same time. So then progressive neurological symptoms. All this put together forms a red flag. And that is what this is saying as a neurological condition. Then are there any other screening tests that can or should be done? Can someone read this, please? So that I will allow others also to be part of these discussions. Please, Huria Jamda and Michael Ezike, please, can you put down your virtual hands?
A screening, can I go ahead?
Yes, go ahead, please.
A screening physical examination should be conducted and any significant finding noted and reported to the physician. A general survey, vital signs, and chest auscultation will be a good place to start. It is possible that the client's presentation and certainly the new onset of symptoms is unknown to the physician, who saw him almost a month ago.
Good, go ahead.
Okay, the next question. Does this patient have...
I think what this is saying is that, sorry, before you go further, you know the red flag we have here is for neurological condition, neurological system. So what this second part is saying is that the patient may have another underlying disease apart from neurological. And that is what systems review is all about. The difference between systems review and review of system is that in systems review, you are asking questions about each of the systems. So all the systems, you ask questions about all of them, but with few pointers that it is the answers to those that will determine whether you want to do more thorough assessment of that particular system. You want to do more follow-up questions of that particular system. You don't see any yellow flag in a system. There is no need to go on and continue to do other tests to see if there is a problem in that system. But the moment you have yellow flags, then you now want to come back, dwell more on that particular system and see if there is truly a suspicion of organic pathology. And this is what is called review of system. So the systems review is looking at all the system, reviewing all the systems. But review of system is looking at one that you have suspected in the systems review so that you can now go further to confirm if it is a red flag that you need to refer. So what this is saying is that since the patient has not seen a doctor for a long period, don't just focus on that red flag for the neurological symptom and just refer the patient. Do further screening so that you'll be able to see if there is any, say, pulmonary underlying disease in the pulmonary system, which is the systems review principle. Can go ahead, please. Does this patient have signs and symptoms of systemic disease?
Please, sir.
In fact,
Can you hear me, sir?
Yes, Mr. Felix.
Hello, sir. Yes, sir.
Yes.
The first 3 points you mentioned, that's under the red flag no stuff, no?
Yes.
Can we actually place them as a red flag or yellow flag? That's the age of the patient, being an alcoholic person and a smoker. Can we call them red flag or yellow flag?
The symptoms come.
It's a red flag. The reason why it's a red flag is because they are combination. Yes. No, if it is just age, smoking, and alcohol use, just these three, it will be a yellow flag.
Yes. So that's why, because the way you put it is looking as if it's a red flag. You know, that's why I want to clarify.
No,
Make you
you
to clarify
didn't
that
listen
area.
very well. Oh, he says so that the first three is yellow flags.
The first three are yellow flag. They form yellow flag.
Okay.
But when you have a combination of risk factors and then symptoms, that is when it now becomes a red flag. And let me not also confuse you. It's not all the time that you have risk factors and symptoms that makes a red flag. You may have one risk factor, one symptom may not constitute a red flag. But this you can see is a combination of 3 risk factors and 2 symptoms. And therefore, this is something that looks like that there's something. And the symptoms there are not symptoms that indicate movement impairment only. It is a symptom that more likely looks like the model of pathokinesiology, a kinesiological model. Because someone mentioned earlier about neuropathy. Remember when we were discussing neuro, we talked about motor neuron disease. So these are issues that require a physician to come in. And therefore, if you have symptoms that look like symptoms of an organic pathology, together with risk factors, it can form a red flag. So what this answer is saying is that these 5 combination of risk factors and symptoms, and the symptoms especially are looking more like symptoms of an organic pathology, together they form a red flag. So can someone help read this, the answer to this question? Does this patient have signs and symptoms of a systemic disease?
In fact, the therapist observed signs of discharge clotting, hence only. Reported oxygen saturation levels sat consistently at 90%, and noted bilateral basilar crackles on the lung auscultation.
Okay. So these are signs and symptoms of a systemic disease. Remember in the last one, the presence of a cough that was productive and greenish was the sign of a systemic disease. And in this one, whenever you have this, reported oxygen saturation levels, SaO2 consistently at 90% and noted bilateral basilar crackles on the lung auscultation, this is a sign of a systemic disease. So can we read the next one?
The client was advised to make a follow-up appointment with the physician, and the therapist faxed a letter of request for follow-up based on those new findings. The client also had carried a copy of the therapist's letter to the medical appointment.
Okay. So does this patient need a medical referral? So what is the result?
The client was diagnosed with lung cancer with accompanying pneumoplastic syndrome. His condition worsened rapidly and he died 6 weeks later. The family later came back to the therapist and expressed their appreciation for finding the problem early enough to make end-of-life decisions. Both children and 3 of the 4 siblings were able to visit with the gentleman before he died suddenly in his sleep.
Okay. So now that question, does the patient need a medical referral? I think straightforward. I will say yes because of this first answer. There is a red flag. Whenever there is a red flag, there is need to quickly refer. Why also does the patient need a referral? This question that asks, do this patient have signs and symptoms of a systematic or systemic disease? The answer also was yes, because of those signs. And therefore, it's a case of referral. Now, what this means is that the physiotherapist observed this and referred. And the result was that a diagnosis of lung cancer was made. Key. Please, Ezekiel, I don't know whether you are still with us. If you are with us, please try to lower your virtual hand. Yes, Mr. Anozie, go ahead.
Yes, Prof. Thank you very much for the clarity you are bringing to the red flags and yellow flags, the differences. And I just want to ask a question regarding, escalating a yellow flag. For instance, we've seen that this patient has risk factors that could be pointing to also a pulmonary problem, which eventually the doctor has been able to find that this patient had a lung cancer, which is there. Now, as you have seen, this patient is a chronic smoker and is also presenting with some of the signs and symptoms that shows that there could be a problem, but it's not really, let's say, it's not really a red flag. But you want to also, because we're also in the era of preventive, medicine and all that. So, do we need to, bearing in mind that we are following the MDT approach? If I find out that this patient is having, let's say this person is a chronic smoker and obviously would require some support to quit smoking or to do some lifestyle modifications, but this is definitely a yellow flag at that point, would I now say this patient does not require a referral, not necessarily to the medical doctor, but maybe to people who do lifestyle support? Let's say if the patient requires, for instance, if there is an obesity as a risk factor and is a yellow flag for my patient, and I know that, this patient definitely would require some referral to the dietitian, would I say at that point, let me just carry out my own within my scope of practice without still making that referral? I want you to really throw more light on the need for medical referral. Is this only for red flags or combination? And at what point do we do? And which, I just want you to just elaborate more.
Okay. Thank you very much. Very, very important thing. All the clerking that you do, any information you pick is going to be used either. Remember, we talked about narrative review and diagnostic review. If you remember our clinical reasoning, sorry, not review, diagnostic reasoning and narrative reasoning. Whatever information you collect from the patient during diagnosis, except for name, that template that we looked at of APTA, at each and every question, I try to explain how we can do a narrative reasoning or a diagnostic reasoning. What we are talking about now is a narrative reasoning. So meaning one question, we can do a diagnostic reasoning on it, and then we can still go ahead and do a narrative reasoning with it. Diagnostic reasoning, that information is adding towards a diagnosis. So it helps us to narrow down to reach a diagnosis. While the narrative reasoning is helping us to think of how to address that particular risk factor or that particular symptom or that particular sign. Remember, I said any information you collect that is negative, you must do something about it. Now, if it is a risk factor, what you are doing is to now prevent it from giving rise to a disease or an injury. And therefore, if you have obesity, you don't just use it to say that, okay, these are risk factors and therefore there's a red flag, we are going to refer. No, you are going to refer that particular risk factor to whoever it is that is going to address it, either to prevent the patient from having a red flag or to prevent the patient from having a yellow flag. Whatever the situation might be, it's a problem, there must be a referral. Alcohol intake, there must be an intervention to help the patient to stop the excess alcohol intake or to stop taking it at all. Smoking, there must be an intervention. Who gives that intervention is another discussion. You now identify who is going to give that intervention, but it is necessary, it's ethical, because it's unethical to leave them with that, because that is why we are collecting that information. Now, another very important thing to take note in this particular case study is the fact that what showed a red flag in the first place was a neurological condition. And that was why I was emphasizing earlier that don't just see red flag in the neurological system and just stop your system review and you refer the patient. If that's what this physical therapist did, by the time the patient goes to the physician and is referred to a neurologist, or maybe right from the level of the physician, they will say, look, there is nothing here. There is no diagnosis, even though there was a red flag. there was no diagnosis of a neurological systemic problem. But the fact that this physical therapist went further to find out and establish the fact that there is a systemic disease affecting the pulmonary system, referral was based on two red flags, that of neurological system and that of pulmonary system. And at the end of the day, what was diagnosed as an organic pathology was that of the pulmonary system, meaning system review has paid off. Going through the systems, identified neurological and pulmonary, and at the end of the day, it was the pulmonary one that was ruled in and a diagnosis of lung cancer was made. So these are really very important issues. But the question you asked, I really appreciate that question, because whatever information we take, if there is need for diagnostic reasoning and narrative reasoning, we do that. We try to solve the problem of the patients item by item, not just looking at the diagnosis. Now, when you go to treatment, to plan your treatment, you don't just give a package of treatment for every patient that has condition. No. You go back to your assessment to say that in this patient, he reports pain, he reports balance problem, he reports a sensory problem. But in this other patient, he reports pain, he reports balance, but there is no sensory problem. The problem he has is cognitive. And therefore, my plan of treatment should be based on the symptoms that each of the patient presents. But do we stop there? You have to go back and look at the risk factors. How do I also take care of them? Prevention is better than cure. If he stops smoking, he will reduce the chances of having a cardiovascular disease. If you reduce intake of alcohol, he will reduce the chances of having these neurological diseases that we have as red flag. So very important. I may have taken longer than necessary to explain this, but I just think it's very important as we clerk the patients to consider those narrative reasonings and diagnostic reasonings. Thank you so much for all those questions and comments. Can you see when we work together, we will understand more and we'll appreciate whatever it is that we are looking at, because a lot is coming from you that myself benefiting from. So that's wonderful. I would have gone to the next system. Maybe that's what I will do. But before I do that, let me just share an appendix that shows some of the questions we ask in the screening. So this is not going to be a case study. This is just going to be questions you ask when you are screening for dyspnea. So it's one thing to say this person has shortness of breath. Now, but what do you do to really confirm that this is really shortness of breath and not something else? So there are many of these documents, but I'm just going to share one just to show us how we can be able to ask those questions. So screening for dyspnea, do you ever have trouble? Because you can't just ask the patient, do you have dyspnea? Or do you have trouble breathing? The way you define that difficulty breathing, one person defines it will be different from the way another person will define it. So that's why it's important to ask those questions. Do you ever have trouble catching your breath? If yes, how long have you had this problem? Is this a new problem? How often does it happen? If a chronic problem, ask, does this seem to be getting better, worse, or staying at the same? Sincerely, if you ask me, there are too many things to ask patients. But are they important? Can they help us identify something that needs referral? No matter how many they are, we just have to consider using our clinical reasoning to be able to know how we can be able to accommodate all these things, because they are all important. Are your activities limited in any way because you don't have enough air or can't catch your breath? How many blocks can you walk before you have to stop to catch your breath? How many stairs can you climb? Does your shortness of breath occur at rest, at night, or with activity? So I won't go through the whole thing, but it's important. But here it's giving you something that will help you with evaluation, with reasoning. Now you have asked the question. How do you interpret those questions that you have asked? If the client reports new onset of shortness of breath and is tachypneic, diaphoretic, or cyanotic, so meaning you now have another thing. You have to find out if this patient has these three symptoms. That is not the interpretation. Remember earlier the question was about, do you ever have trouble? Are your activities limited? How many blocks? There was a question that was asking when it comes. How often does it happen? How long have you had this problem? Yes, so these are questions. So you have gotten that information. So if it is new onset, then assess these three things. Immediate medical referral is advised. If you have the shortness of breath and it is new, just started, and you find out that the patient is tachypneic, diaphoretic, and cyanotic. And that's why I keep telling our physiotherapist, we say anectinic acyanosed afebrile. But believe me, some people just put that information in the folder. When do you say this patient is cyanotic? When do you say the patient is diaphoretic or tachypneic? Very, very important, because the interpretation will not be correct if you have this information and the patient does not have that particular symptom. So you have immediate referral with this. Review medications for any that can cause shortness of breath. Now, someone was talking about shortness of breath being a systemic problem. Can you see further questions that will help you to be able to know whether it's systemic in nature or it is just a side effect of a medication? So any patient that has that shortness of breath, before you refer the patient, ask the patient what medications they take. And as physiotherapists, we need to start knowing what are the side effects of drugs, what are the interaction effects of drugs. A particular drug may not lead to SOB, but when the patient takes that drug and combines it with another drug, the interaction effect may give shortness of breath. So all these understandings are very, very important. So I will leave you with the other forms of interpretations. Very important, because this is what makes us professionals, that we are able to ask the questions, but we are also able to interpret them to be able to say, this is what the problem of the patient is. This is a yellow flag. With this, my interpretation, I can see that it's not going to move into a red flag. All I need to do maybe is it can be a referral to say that, look, this medication that you have given this patient, it is affecting their shortness of breath. Is there any medication similar to that that you can change that does not have that side effect? So it will be just to refer so that they change the medication, not that you want them to go and get a diagnosis of an organic nature. Because the shortness of breath is not a red flag indicating an organic pathology. It is just as a result of the medication that the patient is taking. So let me just open the floor if there are comments before we move to cardiac issues, cardiovascular issues. Any comment?
Hello, Prof.
Hello, yes, go ahead.
Yes, sir. The the idea of shortness of breath,
yes,
being a yellow flags, I think it depends on the condition one is handling.
Okay.
If you are treating an asthmatic patient, that suddenly you see that this person is running out of breath, and he doesn't have his medication with him. I think such a thing should not be kept. I said, yes, I know you're asthmatic and you can have shortness of breath. I think that kind of scenario should be referred appropriately. Or should we? I understand what you are saying, that just having shortness of breath, if you are managing an heart failure patient, we know one of the symptoms is shortness of breath. So if you have such a patient and you know that the patient has a diagnosis already, it may not bother one much. But treating a patient and just suddenly develop a shortness of breath, that rest, keeping the patient to rest for a while does not relieve it. I think sending that patient to emergency or referring the patient will be better than patient dying on our hand. That's just the way I look at it. I just want to share my own opinion to know how to.
If you remember, last on Saturday, when we discussed cardiovascular system, I think there was one of the red flags that we said when pain of angina comes and it is not responsive to nitroglyceride, that it is a red flag.
Yes.
So if a patient now begins to have that pain, but he is a known heart disease patient who is on medication and the medication is there, the moment they begin to have it, they take that medication and the symptoms go down. And they are aware already. Their physician says, when this symptom comes, when you take this drug, like the asthma you are talking about, this patient now develop the shortness of breath. They quickly take the medication or the inhaler, whatever it is, and the symptoms go down. Is there a need to quickly refer the patient? No, there is no need to. Yes, this is a clear case. There is no need to refer. But if the symptoms come and the medication is not there, is it going to the physician that's a priority or getting the medication that's a priority? I believe getting the medication is the priority. It's only when they try the medication and it does not bring down the symptom, then you'll now begin to think possibly there is another underlying disease that is making that drug not to even work on the symptom. Because there is another underlying disease, we need to find out what it is and also give it its own medication. That is when it will die down. So what we are saying here is that when the shortness of breath is there, we don't just say, okay, let's quickly refer. Because what's going to happen is that by the time he goes to the physician will say, have you taken your drug? They say, no, I've not taken it. Then why is the physiotherapist sending you to me? Why can't he send you to go and get your drug? Or possibly if it is the drug that is given the side effect of the shortness of breath, said, well, look, I know about this. Have I not discussed with you that you just have to bear with us? There is no other drug that is going to suit you but this one. It will give you just a temporary shortness of breath, and it is not going to affect you as a disease coming in or injury coming in. And therefore, knowing that, even as a physiotherapist, when that shortness of breath comes, and you said, okay, when last did you take your drug? No, it's just a few minutes. Oh, that's what's happening. I know your doctor has already explained that this is expected and there is no other drug that we can change, and therefore bear with it. So because it just said 2 weeks, you are going to complete that dosage, and then that shortness of breath will go. So this is, I think, the situation. Whenever we can't explain what we have on ground, and it's a red flag, we refer. But whenever we can explain it, then we go with what the explanation says. Because what I don't want us to do is to be sending patients to physicians, and at the end, what Dr. Fan Achubo was complaining will now come to pass, that yes, you don't have the capacity to send patients to us, and therefore, please always send them through a physician or a general doctor that is going to assess them and know when to refer them to us. So thank you so much. But Dr. Achubo, I really understand where you're coming from, and I agree with you very strongly that the situation will determine whether there is need of a referral or there is no need for a referral. Thank you. Someone is trying to speak? Is the person trying to speak?
So can I just chip in something, please?
Yes, please. Go ahead. Go ahead, please.
Yeah, thank you very much. Is in this case of shortness of breath, because we know that anything that affects the respiratory system, and we'll be talking about, has a link with oxygen saturation. this patient is in shortness of breath, normally with my experience, is the first thing we need to do is to, if we are doing that quick review and we're asking questions and we're doing a talk test and this patient is not able to sustain conversation, you know that this shortness of breath is really worse. Then you position the patient in a particular way to be able to see if they can get more and start teaching some breathing exercises, trying to control that breathing and see if there's a problem, and do a quick respiratory assessment, just like you have stated out here. Do auscultation if there's any need to clear the airway immediately, to suction the patient, to do one or two respiratory maneuvers to help the patient to calm down their breathing. But if you have done that and the patient is not the SpO2 specifically goes at a very critical level, usually once it's less than 90, you're already thinking there's a problem somewhere. Especially if the patient is not a known respiratory, does not have any underlying respiratory condition already, then there's a big problem. You need to escalate immediately, because we know that the timing of if the brain loses oxygen for up to 4 minutes, there could be a permanent brain damage. So you don't want that to happen. And also the effect of low oxygen saturation in other organs of the body. So for respiratory particularly, I think we should just like the previous people, and you have explained to that the timing is important. We will definitely have to do our interventions immediately and check all those things. But if we have to wait, maybe probably it's getting patient getting their medications or something like that, and this thing continues at the spot while you are there, then I think at that point every emergency situation is usually from either a cardiac problem that happens immediately that now spins into a respiratory distress. So if a patient is in respiratory distress and we are not able to manage it, I think it should be escalated immediately.
Thank you very much. What we are discussing now, I'm very happy with it, because this is what shows that this person is a professional. This person has that capacity to be able to assess and interpret the assessment, make evaluation, and then make judgment. That's why we looked at all these topics earlier, clinical reasoning. And we chose clinical reasoning to come before this because it will help us to be able to understand the issues and evidence-based practice that we did. Remember the components of patient management, assessment, evaluation. And that evaluation, we said, this is what is really difficult for us, because you need analytical cognitive processes to even understand the information that you need to digest before you even think of interpreting it. What we are dealing with in systems review, more than 80%, is about interpretation of what we assess or what we do to patients. So thank you so much to all of us, because we are all putting together our thoughts, putting 1 and 2 together to be able to give rise to 3, and then we make decisions. Wonderful. Thank you very much. So now we are looking at special questions to ask: chest and thorax. So especially the heart. When you have diseases or injuries that affect the chest, it could be a musculoskeletal problem that can indirectly affect the lungs or the heart. It could be neurological. It could be pulmonary. It could be cardiac. So whenever or epigastric. So what questions do you ask to be able to know if the problem is musculoskeletal? So maybe there is an accident. Problem that affects the area of the brain that sends impulses down to the heart or to the lungs or to the chest. Or maybe it's not in the brain. Maybe it's in the cervical spine. Or maybe it's in the peripheral nerves, either those that supply muscles or those that supply the viscera, that there is a problem. So you want to ask questions to be able to identify. The problem we know is in the chest, but is it musculoskeletal in nature? Is it neurological? Or is it cardiac? Or is it Have you strained a muscle from repeated forceful coughing? So the patient is coughing, say, I have pain in the chest. So what you want to do now is to identify, is that pain movement impairment related, or is it an organic pathology but related to the musculoskeletal system? Because you can have the musculoskeletal system, but you have physical diagnosis in the musculoskeletal system, or you have an organic pathology
We lost your voice.
Have you ever injured your chest? Does it hurt to touch your chest or to take a deep breath? Example, coughing, sneezing, sighing, or laughing. So you are looking at myalgias, you are looking at fractured rib, you are looking at costochondritis, myofascial trigger point. These are pathologies. And usually these questions help bring out that suspicion that even though it's a musculoskeletal issue, but it is an organic pathology related issue. Do you have frequent attacks of heartburn, or do you take antacids to relieve heartburn? Remember I told you during our clerking using the APTA template, there is a particular section on drug history. And we said the type of drug that the patient takes might even give an indication of what the diagnosis is. So the patient comes to you directly. They didn't go through someone to refer them, but they have seen a medical person in the past. And they said they can't remember the diagnosis. And they just present the drugs to you. So the drugs they take or the prescriptions they were given can indicate what sort of past medical conditions they have had. So if you ask, do you have frequent attacks of heartburn? Or do you take antacids to relieve heartburn or acid indigestion? So non-cardiac cause of chest pain, abdominal muscle trigger point, or gastrointestinal disorder. So you don't have this, and the patient still has pain in the chest. It could be any of this, because when you have gastrointestinal disorder, it can give symptoms that are in the chest, and you'll be thinking that it is a musculoskeletal problem, but it is not. It is coming from the gastrointestinal. Does chest movement or body or arm position make the pain better or worse? Of course, whenever you have chest movement and pain changes, or whenever you have body or arm position changes and pain changes, it could be a musculoskeletal. But remember, I think we once discussed when the patient raises their hand to reach out to something and the pain increases or shortness of breath, that it's an indication of an organic pathology. So these things, we need to look at them. Is it reaching up and sustaining, or is it just raising? Before it even gets above the head, you begin to have pain. So we need to ask these questions and then try to interpret it based on the symptoms that the patient presents with. Do you have any trouble taking a deep breath? Weak chest muscles, secondary to polymyositis, dermatomyositis, myasthenia gravis. So we are now looking at organic pathology. Do you have any trouble taking a deep breath? So they can't take a deep breath because the muscles are weak. But what is the reason? It can be organic pathology related. Does your chest pain ever travel into your armpit, arm, neck, or wing bone or scapula? So you start to think of thoracic outlet syndrome. So these are things that are organic pathologies, but related to neurology, but that are situated around the chest area. So pulmonary, have you ever been treated for a lung problem? If yes, describe what this problem was, when it occurred, and how it was treated. Do you think your chest or thoracic pain is caused by a lung problem? Have you ever had trouble with breathing? Are you having difficulty with breathing now? Do you ever? So these are questions related to pulmonary that we have looked at earlier. But let's just see if we have any interpretations. What symptom stops your walking? Do you have any breathing aids? So at least the breathing aids will indicate that the possibility that it is a pulmonary problem. Just asking them, do you use a nebulizer, humidifier, ventilation devices? It's given an indication that there's a problem that is pulmonary in nature, even though initially the suspicion was the chest. Do you have a cough? Not whether the person smokes, for how long and how much. So this is a lot of information to digest. But what is important is not asking the questions. These are interpretations. When you ask the question, what does it mean? What do I suspect? There's a problem in the chest. Is it musculoskeletal? If it is musculoskeletal, is it movement impairment related, or is it an organic pathology? If it's movement impairment, we go ahead, we make a physical diagnosis. If it is an organic pathology, we go ahead, we refer to the appropriate person, either through a physician to the specialist or to the musculoskeletal or orthopedic surgeon. If it is pulmonary, to the pulmonologist. If it is cardiac, to the cardiologist. Whatever the rule or regulations are in our institutions or organizations. So very important. These are all questions. Can you see cardiac? Has the physician ever told you that you have a heart trouble? Have you recently or ever had a heart attack? If yes, to either question, do you think your current symptoms are related to your heart problems? Do you have angina? If yes, describe the symptoms and tell me when it occurs. If no, pursue further with the following questions. Do you ever have discomfort or tightness in your chest? So you don't just ask the patient, do you have angina? Especially in our environment, people would not know whether this pain in the chest is angina. But the question that will help to know if this is a suspicion of angina, do you ever have discomfort or tightness in your chest? Have you ever had a crushing sensation in your chest with or without pain down your left arm? Do you have pain in your jaw? Joe, remember the pictures that we show? How do you know that there is pain in those areas that we shot the pictures? We only shot the pictures. But these are the questions that you ask to be able to know if a patient has that combination of presentations across the different places that we talked about. We said the jaw, the neck, the trapezius muscle, the shoulder, and then the medial part of the left forearm and arm. So how do you ask the questions? To be able to know if that distribution is there, so that you'll not be suspecting musculoskeletal system, because this is a distribution of a cardiac presentation. So there are a number of them. We look at rheumatic fever and endocarditis. Have you noticed any skin rash or dots under the skin on your chest in the last 3 weeks? Interpretation, possibility of rheumatic fever or endocarditis. Have you noticed any other symptoms? Shortness of breath, sudden and unexplained perspiration, nausea, vomiting, dizziness, or fainting. Cardiac. Have you used cocaine, crack, or any other recreational drug in the last 6 weeks? So looking at pain at night, suspicion of cardiac ischemia, or psychogenic or stress-induced. Then epigastric, GIT. Have you ever been told that you have an ulcer? That can make a patient to feel tightness in the chest, and you'll be thinking it's pulmonary or it's cardiac. Does the pain under your breastbone radiate around to your back? Remember GIT. When we looked at the picture, we saw some indications that there is pain in the back? Or do you ever have back pain at the same time that your chest hurts? So the back pain is not there. But the moment your chest begins to hurt, you now begin to have back pain. So these are symptoms that indicate that there may be an epigastric problem. Have you ever had heartburn or acid indigestion? If yes, how is this pain different? If no, have you noticed any association between when you eat and when this pain starts? So what we have looked at now is just a follow-up from what we had in the slides. This is more practical, more clinical. What we saw there was just to say this is the distribution. This is what shows that there is a red flag or a yellow flag. But how do you ask the questions to come up with the presence of those symptoms, and you interpret them to be able to say there is a yellow flag or there is a red flag? These questions are very important. I'm going to send all these documents that we have discussed, because what we have here is something that's beyond a 2 or 2.5 hour workshop. It's much beyond that. But at least what I'm trying to do here is just give a guide, like teach the student how to learn. So I'm not giving you the skills or the information. It is just to guide. How do we learn? How do we apply? What is important is that there are symptoms and signs and risk factors. And there is interpretation of those. No, before the interpretation, we have the knowledge of the risk factors, the symptoms, and the signs. Then we are able to assess them. And much of what we have discussed here is how to know if those symptoms, signs, and risk factors are there in that patient. Then we now do the interpretation. And the interpretation is trying to say, from what system is this problem? This pain is from the chest, but it could be a pulmonary source. It could be a cardiac source. It could be a musculoskeletal source. It could be a epigastric source or neurological source. Now, how do I know which one is it? Then number 2, if I know what system the problem is coming from, how do I know that it is an organic pathology so that I refer? Or how do I know that it is a movement impairment issue so that I keep it and I go ahead and I diagnose? So there is a lot to digest. But believe me, if it becomes part of you, it becomes automatic. You just see the information, you interpret it, you make a decision. And that is clinical reasoning and clinical decision making. We have to go back and also master that, because it guides us in all these processes that we are looking at. So apology, I have spoken a lot, and I hope it's not confusing. I hope it's sending message that will help when we do this practically with patients in the clinic, that we get something out of the whole process. Let me open the floor if there are comments or questions. Okay, I can't see any. I believe bombarded us with a lot of information. Maybe okay. So let's have Anozie. Yes, in Wabunwani. That's why I kept shying away from that name. But let me start to try to pronounce it.
Yeah. I'll give you a 7 over 10.
Okay, thank you. I appreciate that.
Yeah. Thank you very much, sir. I would really say this workshop has been very stimulating for me. It's opened my eyes in some areas, and the importance of system review, clinical decision making, clinical reasoning, and everything to our professional upgrade. We can't really overemphasize that. And I'm really, really beginning to appreciate the fact that one has to really have a detailed knowledge of different pathologies and signs and symptoms, differential diagnosis again, look into it again. And so when the questioning comes in, you question from the place of knowledge and you're able to relate different things together and able to identify. The major thing for me is the fact that it now helps us to be able to have effective communication in the MDT where we're able to identify things on time and also refer when we need to refer. It also shows that part that we have really upgraded our knowledge. But then I'm just thinking, with the caseloads that we're having in our teaching hospitals and different hospitals per se, if we really want to have a proper system review approach to, assessing our patients, do you think it's really feasible for one to be able to, maybe in the initial assessment, we may be able to do, but for a patient who comes for a follow-up review and you have a lot of patients lined up, and if you really want to question different systems, as they're asking, you need to screen. Is it something that is recommended to be done only on the initial assessment, maybe probably at a review, then at discharge? I want to know, is this something you would encourage us to do at each point? And again, with considering the caseloads, is it really feasible to really do this comprehensive examination? Thank you, sir.
Thank you very much. I think I've said this several times, that we are the ones that create problems for ourselves in our hospitals. The hospital will say we must see as many patients as possible to generate revenue. Sometimes they'll say we'll not pay for accreditation because you did not generate anything. You are collecting 2,000 per visit, maximum 5,000 per visit, and you see each patient for 20, 30 minutes or maximum, at maximum 30 minutes, 40 minutes. At the end of the day, you think you have generated funds, but the primary thing why you are doing this, you have not achieved it, because the patients are not getting better. They are not being discharged because you have not even identified what the problem is. There is no way you can target a very good treatment when you have made a wrong diagnosis. It's an organic pathology. You keep giving short-wave diatomy or exercise. The patient one day will discharge themselves. You will never have a discharge plan because you are not targeting the source. So that's number one. There is no way that we can continue to follow what our CMDs say, that we must see 50 patients when we only have 3 to 5 people in the department. Not possible. We need to now begin to get documents that we'll use to convince them that we need more time to see our patients. Clinical practice guidelines are there. All this information that we have systems review, they are coming from evidence. Let's pack something and show to them. Let's also update ourselves, advance ourselves, to the extent that we give the patients something that makes them feel impressed. They are the ones that will speak for us when it gets to policy making in the hospital. Someone will be a friend to the CMD, and you say, wow, wonderful. I have an example of a hospital that the CMD employed more people, and he told us, do you know how I get more than 50 for the Department of Physiotherapy? We said, I don't know. That time I was president. He said, they treated me, and they were able to identify problems I never expected physiotherapists will identify. And he said, when I went back, do you know what I did? He was trying to whisper. He said the slot was for medical lab science, but I picked the slot and I gave it to physiotherapy. And that was how. So if that man, a HOD will go to him and say that, sir, I need 1 hour to be able to assess patients, will he protest? He will not, because he himself benefited from that expertise that the clinicians had. So this is really, really very important for us to take note of. I've said too many things, and I think there was something that you asked that I wanted to add to, but I can't even remember because I was focusing on this. This is something that has been in my head for long, trying to accuse us as physiotherapists of just wanting to do short time. Okay, the second thing I wanted to say was that it is not all circumstances that you identify red flags in the initial assessment. It is not. The case we discussed, The one that Dr. Ajiboye was saying, they didn't do proper assessments. Maybe that's why they missed some of the things until at a later time. But at least they got it at a later time. Some things may not manifest. Some things you wouldn't have the chance in the first assessment to pick them. But in the follow-up, when you are not going to do 1 hour of assessment, you are only going to give treatment. And while you are giving the treatment, you will assess, you will ask questions, and you'll be able to identify something. Then at that point, you refer. It is better than leaving the patient to discharge themselves because you have not been able to identify it. It's better to be late than not to be able to identify the presence of an organic pathology at all until the organic pathology sets in and it will be difficult to treat, and then someone will recognize it. So I think these are the issues. Sorry, I had to take a long time to explain this, but these are the issues actually. Any other comment? I can't see any hands. I can't see any.
Sir, can I comment,
okay.
sir?
Yes, comment, please. Go ahead.
Okay, thank you, sir. So I'm really glad with this teaching we've been having for a while now. I think you have really done a yeoman job concerning this system review and clinical reasoning. I remember years back, we used to have challenges in getting more hands in physiotherapy departments. That is, convincing the management to even employ more physiotherapists to work in the departments we have in the hospitals, because they look at it as, okay, what are we doing? But when the issue of specialization came in, it became so expedient that they need to employ more hands, to work in the physiotherapy department. Because, okay, well, we have now physiotherapists that specializes in the area of cardiopulmonary, in the area of orthopedic, in the area of other field that we have on ground. So we need more hands to work in our physiotherapy department. Then I believe this systemic review and go into details to be able to examine our clients better can be another strong basis for us to argue our point that yes, if you want us to get more clients being assessed or treated, we need more hands, because we can't be rushing through our patients because we want to give them the very best, So I think this can also be a way of arguing out our points, to let them know that yes, more hands are needed, at the physiotherapy department to be employed to help us give the best, to our patients, so that we don't just rush them through assessments without necessarily, coming to a logical conclusion on what we need to do or what the findings are, so that at least it can also give a good name to the hospital, at least, as an entity. So I think this can also be a vital point, that we can base our argument on in discussing with some of the managements, in our different hospitals, that yes, more hands will be needed. If you want us to attend to more patients, then give us more physiotherapists, to go to look into those areas. Thank you so much, sir.
Thank you. Thanks a lot. So I think we'll all put our hands on deck, support each other, be able to get information, advance ourselves, get the confidence, and we begin to talk to relevant people. At the end of the day, I believe we'll get something better than what we had before. So I know time is going. I'm going to stop at around 10:30. So I'll just look at one more under cardiovascular. We have looked at the heart, chest area, and the heart. I just want to quickly show us something about DVT, because DVT is an organic pathology, and there is this clinical decision rule. They call Wells clinical decision rule for DVT. This is when there is an active cancer. So within 6 months of diagnosis or receiving palliative care, you give a score. So for each item, you give a score, and at the end, you are going to see the percentage of risk of having DVT. When there is paresis, or recent immobilization of lower extremity, so possibly if there is a cast, it is not a paralysis, but because it was immobilized. So bedridden for more than 3 days or major surgery in the last 4 weeks, each will have a score of 1. Localized tenderness in the center of the posterior calf the popliteal space or along the femoral vein in the anterior thigh or groin, give a score of 1. Swelling in the lower extremity, the whole lower extremity, when there is unilateral calf swelling, more than 3 millimeters larger than uninvolved side, and therefore you need to measure both sides. When it is more than 3 millimeters larger on the uninvolved side, score of 1. Unilateral pitting edema, one side, collateral superficial veins, so non-varicose, you give a score of 1. An alternative diagnosis is as likely or more likely than DVT. Example, cellulitis, postoperative swelling, calf strain. So at the end of the day, if you get -2 to 0, low probability of DVT, 1 to 2, moderate probability of DVT, when you get 3 or more, you have high probability of DVT, which is about 75%. So the likelihood of having it, especially when you have 3 or more, high probability, you know it's a red flag and you need to refer because of the DVT. Low probability, you know, it's like when you think there is likelihood, there is an alternative diagnosis, not the DVT, and therefore you are now looking at that diagnosis. Is it something within your scope of practice, or is it not, but it's another condition that also may require referral, but not to the cardiovascular team? So this is another thing that's important for us to study and know how to apply, so that when we see any of these signs, we can follow up on the others. We give the score. We now look at the percentage or the likelihood that DVT is there. Then I think finally, I'm going to just quickly look at GIT, because I think it was also part of what we discussed on Saturday. I may take only 1 or 2 from this, and then we'll have general discussions, then we'll close. Please remind me if we have I think it was, we looked at a case report on neuro, we looked at pulmonary, cardiovascular, and now GIT. If there is any other system that we considered on Saturday that we have not taken a case report, please just let me know, so that we'll quickly look at one case report from it. But I have a feeling that it was only these 4 that we looked at. So this is something that is a case example of colon cancer. Please, can we have someone read the brief history?
6-year-old university professor consulted with a physical therapist after twisting his back while taking the garbage out. He reported experiencing ongoing painful low back symptoms weeks after the incident. The objective assessment was consistent with a strain of the right paraspinal muscles, with overall diminished lumbar spinal motion consistent with this gentleman's age. Given the reported mechanism of injury and the results of the examination consistent with the musculoskeletal problem, a medical screening examination was not included in the interview. A home exercise program includes stretching and conditioning components. When the client did not return for his follow-up appointment, telephone contact was made with his family. The client had been hospitalized after collapsing at work. The medical diagnosis of colon cancer was determined. The family reported he had been experiencing digestive difficulties off and on and low back pain for the past 3 years, always alternately and never simultaneously. The client died 6 weeks ago.
So this is a case that the therapist did not do the system review. A medical screening examination was not included in the interview because of the indication that there is musculoskeletal problem. Can you see why I told you that in the United States, the APTA template, you don't even ask of the chief complaint before you do your biodata, past medical history, family social history, and drug history, because of this particular situation. Can you see that they were not able to detect, even though the family knew or observed these issues of digestive difficulties, low back pain, and the alternating symptoms between the back and the GIT? That was not there. So what are the questions? What are the red flags? What other questions about symptoms and signs the therapist should have asked to assist with differential diagnosis? What other questions the therapist should have asked before finishing the history and interview? Can we respond to this? Let me know if you want me to move to the answers again. I know we are all tired and exhausted because it's not easy when you have something that should be run for months or weeks, that you just do it within 2 or 3 hours. So I can imagine why we can be exhausted. But can we just have 1 or 2 comments on this? And then we'll just quickly go to the answer. I think this is a straightforward thing. I was expecting many hands.
Hello, I think they
Hello?
didn't cut the red
Yes, sir,
flag
go
here.
ahead.
The red flag here is the medical diagnosis that was reported, but
Okay.
not the physiotherapy, that is the colon cancer.
Colon
So,
cancer.
but it was missed by the physiotherapists because they only concentrate on the musculoskeletal, the low back pain, whatever. So if I mean they asked the problems about any issue, any problems, any issue of any problem about digestive problems or whatever, you should be able to have pinpoint before medical diagnosis was made. Or any issue of cancer in the family or any problem, any medical treatment received before that has to do with the management of cancer, will have that one out. But precisely the red flag later on that was discovered by the medical diagnosis is the colon cancer. That is
okay.
We can't hear you clearly. Speak up,
I
please.
think the network, possibly the network, it keeps using.
Hello, and I'm saying the precise red flag here is the colon cancer, which was missed by physical therapy because they on the musculoskeletal aspect that has to do with the back pain. I didn't mean that the therapist went ahead to ask question about the what relate issue of any digestive problems, any medical treatment that he has received, whatever, will have been able to pinpoint to the red flag that the medical diagnosis of
colon cancer
discovered colon cancer. Yeah.
All right. Thank you very much, sir. Michael Ezekiel.
Hello, sir.
Yes, Michael, go ahead.
Yeah, so, sir, red flags that I see here should be only at the time of assessment, should be only that ongoing painful low back pain that he was feeling, because it's not. We are looking at musculoskeletal, system per se, an ongoing painful low back.
Gloria iPhone, please help us mute yourself. If Hafiz is there, you are the host. Can you help? Good. Okay, go ahead.
All right, sir. Thank you, sir. So, that ongoing painful low back pain, during the initial assessment that was done, the ongoing low back pain is something that should have, piqued the therapist's attention, because it's not, when a patient comes to the clinic and tells you, I'm having pain, in my, let's say, my low, let's say it's in the vertebra, like I'm having pain in my back, and then it tells you that it's something that keeps going on and on and on. It doesn't stop, and it's so very painful. It's already a red flag on its own, because it's not something that has a moment of respite for this patient. It shows there is something else wrong somewhere. So the mistake that the therapist made was not conducting further assessment aside from the usual physical examination that he did there for that patient. Well, aside from that, at the time of assessment, there was no other red flags there except for that ongoing painful low back that the patient complained of. And he's saying that it just started 3 weeks after the incident even happened. So it's something that is still paining him, and it's still paining him so much. 3 weeks, it's paining him now, and he tells you this is how it is for him. It should already point you towards something else. It should not have, narrowed your mind to just doing a physical examination, because it's not enough. And so that's the mistake that the therapist made in this situation.
Okay.
Thank you.
Thank you. Actually, if you look at the last statement, you find out that the relatives, the family reported he had been experiencing digestive difficulties off and on and low back pain for the past 3 years. So you are right, the therapist did not get this. This was there, but the therapist did not get that. Sorry, I shouldn't have made this statement because I have other hands up and I don't want to preempt what they wanted to say. So let me just keep things to myself. Mubarak Amin. Mubarak. So Michael, please drop your hand.
Hello, sir. Thank you for the presentation. Sir, what I would like to say here is that there are some things that the therapist has forgot to ask, like the onset of the pain. The onset of the pain shouldn't have been only the twisting. Like, it should be asked on, has he had similar symptoms before or not, so that the therapist can identify whether it was that twisting of the back that brings about that pain, or it has been an cumulative effect of other this thing. And for the fact that the symptom has been consistent, it should be a pattern of progression should be consistent for 3 weeks. I think a second thought has to be brought in to ascertain. And then finally, sorry to say, you have said it, though I had it in mind. It's about the past history of the pain, whether it has been there for how does it affect his activity, and effect of activity on the pain also is something to be asked, because musculoskeletal pain usually it's affected by activity and rest, while systemic pain and cancer pains, they rarely have activity rarely have influence on such pains. I think those are the things that should have been put into cognizance before dwelling more on the physiotherapy side. The patient should have been evaluated more and get diagnosis, referred for that diagnosis. Thank you, sir.
Thank you. Thanks a lot. Well done. I agree with most, but just one part that I think we need to be careful making that general statement that activity, musculoskeletal, change with activity, but most others not. But remember when we did cardiac and pulmonary, and usually the question is, especially those questions we asked about how long does it take you to wind up? Is activity when you do it, so the pain of angina, remember we talked about pain of angina, and then cardiopulmonary pain or pulmonary pain. So I agree with you that what you mean directly, you move a joint and you feel pain. But if it is from the pulmonary, when you move or you palpate, you don't have change in pain. But because movement is dynamic, Movement could mean when you climb stairs, it's a movement. When you walk for a long distance, it's a movement. So those types of movement can also increase pain of cardiac pain or pulmonary pain. So just to give a little clarification on that, but I agree with you on most of the things that you have said. Thank you. Fatima Sani.
Yes, sir. Good evening. Thank you for having us tonight. I think the red flag here is the age of the patient. At least when a 66-year-old patient presents to you, you need to thoroughly do all the necessary system review, especially the cardiopulmonary, the GIT, and even the urinary system, especially because men above 50, they present with issues of prostate, and it's a red flag actually. So I think the age of the patient, it's a very important factor for the clinician to thoroughly check all the system before he conclude his diagnosis and management. Thank you.
Thank you very much. Just a little correction. I agree very strongly that when someone is at that age, it's very important to be thorough in checking the systems, because at that point we're expecting generative changes and the systems will be affected. But age alone can be a yellow flag, but not a red flag directly. But when you see the age and you follow up and you see other risk factors and symptoms or signs combined together, then it can lead to a red flag. So that's just a little clarification that I think is required there. But I agree with you very strongly. Everyone that is around that age, it gives that motivation more than someone at the earlier ages to check all those things. Mr. Anozie wanted to. Okay, yes, thank you. Yes, Anozie, if you are there and you want to speak, go ahead. After you, then Mr. Felix, and then on the chat forum, I can see a hand, Tom Akin. So we'll take these three before we look at the answer.
Yeah, thank you very much, sir. Just like a lot of people have really mentioned good points here, and for me, looking at this patient with the age coming with the back pain and all that, and from the knowledge we had gained from previous trainings, we are able to now establish that we are not just looking at pain as coming from the musculoskeletal origin. We are now looking at pain. That pain could be neuropathic, it could be neurogenic, it could be referred pain. It could come from different sites. So at this point, for this patient, even without the age of the patient now, I'm no longer seeing pain just from the aspect that it's coming from a localized area. I'm also seeing it. So I'm going to probe further. When I'm asking about pain, I'm going to ask about the nature of the pain, what relieves the pain, what aggravates the pain. Obviously, for this patient twisted the back, but obviously it was missed that this patient has been having a background low back pain that has been there. Now, this is like an exacerbation of that low back pain from an activity that he did. So if we are not careful, we would have just said, oh, it's just the strain. He could have strained the muscles, but there was something also under there. Then the system review, which my other colleagues have mentioned that should have also probed, would now find out if there are other symptoms that are, towards that point. If we have done a good system review, we'll be able to be thinking about if there are other things that we can find out in the red flags and yellow flags in different systems. Then we're able to get back to the point and be able to make a referral first, because now this patient has, I'm just thinking of what usually happens. Sometimes if this patient were to be admitted in the hospital, it's easy for them to come and write like, okay, physiotherapy assess the patient and you prescribe an exercise, and later on this patient now had a crisis. They could just write patient died after physiotherapy for some people who are very mischievous. And meanwhile, it's not you per se that did that, but just to point our attention that now we are beginning to shift our mentality from just looking at the physical problem for the patient that we can see. We'll also now be looking at the systems so that we'll be able to upgrade our practice and also be able to communicate well and also be able to help these patients on time, because we found out that a lot of times the problem we have with our patients in terms of prognosis is timely intervention. If they don't have that timely intervention, which this training has helped us so much more to know the importance of being able to identify things on time and escalate and make referrals, and then we will have issues. So it's really an eye-opener for us. So just looking at a patient, we'll no longer be thinking of, oh, is it just because he fell from, even if he fell, and I like the way Prof has pointed it out, that in that template, when I look through it, it doesn't just make you to just come and start asking the patient what brings you to physiotherapy now. It makes you to go through all those systems and identify everything before you even talk about that. That makes you a more holistic person in terms of assessment. So thank you very much for everyone who has contributed, and thank you, Prof, because I can't really, I would say this is an eye-opener, and this is just a stimulating, a taster class for us to now go more in depth into assessing our patients very well and gaining more knowledge that could help us to be better clinicians. Thank you, sir.
Thank you. Thanks a lot, sir. Mr. Felix.
Hello.
Hello.
Thank you
Yes.
so much, sir.
Felix is on the line. Let
Okay.
Felix finish. Then
Yes.
Uche, you can go and yes, go ahead, Mr. Felix.
Yes. Okay. Thank you so much for the opportunity, sir. From the what we are seeing, clearly written, you can see that the man has been having a sort of organic pathology, from the GIT system, that has been referring pain slowly and gradually to the affected area, over some period of time, but was not too clearing enough. But you could see that, okay, there's a systemic problem, that this man is having, which is very clear from the last two sentences there, concerning the digestive difficulties up and on problem that he has been having for the past 3 years. Then also, I believe there's also, we have some movement impairments too, or lifestyle problem with the prof. You see, many times, most professors or even lecturers, their lifestyle also dispose them to challenges like this, when it comes to their musculoskeletal issue, because the way they sit, the way they comport their back, doing their desk work over time will also add to the problem they're having. And also, we could say that it was why trying to lift the garbage, that he sustained that challenge to his back. Apart from the systemic problem that he's having, that is contributing to the problem over a long period of time, there's also what a musculoskeletal system problem that also added to the whole issue. By the way, has lifted that garbage, causing some strain at that back. Maybe he used no wrong lifting technique, and also maybe his lifestyle over time, the way he has been sitting, doing his work, has also contributed to weakness of the muscle of the back, for him, with the systemic problem he's having with the digestive issue, that he has been having. So all this, contributed, in the long run, to the challenges, he now presented with eventually. Thank you so much, sir.
Thank you. Thanks a lot. These are very stimulating discussions. Adding
Thank you.
To all. Yes, Mr. Uche. Okay, go ahead, Mr. Uche.
Yes, thank you, Prof. Thank you very much for all of these eye openers. And in this particular case, brings a lot of us to thinking, because most times we seem to be one-sided in assessment. Yes, like Prof had rightly pointed out, the age is not just a red flag; it's a yellow flag. But then combining it with the 3 symptoms, low back symptoms, pain symptoms lasting 3 weeks even after the incident, that calls to question that something will be happening. And just like the last speaker said, I wanted to also add that if this prof had been doing this garbage takeout in the previous weeks or days or months, could it be that he lifted something more different, I mean, heavier than usual? Because, of course, like I said, now because we got to the end of this story, that 6 weeks later, the client passed. So we're now beginning to, but ordinarily, I would have said that if we had looked holistically to what might have contributed to the twisting of his back, so like I said, could it be that the weight of the garbage is more than usual? Could it be the way he lifted was different from before? Then the other question is, in as much as this is like a reported, it's a reported summary report of whatever was written on the patient's history. But here, I want to say, could it be that the prof also didn't give all the information? Could it be that he had hidden something to the therapist? Because if the family already had this information about experiencing digestive difficulties on and off, and then low back pain for the past 3 years, it looked like the low back pain, or rather the pain at his back, only started after he took out the garbage. Could it be that we didn't probe, or the therapist didn't probe deep enough to know if he's had episodes of back pain prior? Because now I'm beginning to wonder, did the pain just start from the twisting? Because if someone comes to me and say, I had a pain from lifting, taking out the garbage, and I ask, have you ever had such pain in the past? I think that's a typical question. Could it be that the prof didn't give all the information? Because that also calls to question the idea, probing patients when you're asking questions. Could patients hide things? Is there a way that we can force out information from unwilling patients? Because certain people might want to keep certain things. They feel maybe it's not your business, maybe it doesn't concern you. You probably might have had reasons to suspect, something happening in his system. Maybe he's had some upset around his abdomen, all of this in the past, but those were not mentioned, either because the therapist didn't bother to ask or they didn't deem it necessary to ask. But I'm just again trying to think around the entire scenario, because for me this portrays a typical assessment in a regular, very busy clinic in our plan. So where you have a lot of patients waiting, and then someone walks in and then tells you I had a back pain, and then but you really have all the time to start to again bringing back to what Prof had said, that you need to look at the institution setup and different department setups and organizations in our various institutions to be sure that we'll have adequate time to screen our patients properly. Thank you very much.
Great. Thank you so much. Very interesting perspectives from everyone. I can see on the chat forum, Tom Akin raising hand. Are you interested in speaking, or is it a mistake that the hand is up on the chat forum? Just let us know so that we can go to the answer, and then we'll round up and close. If you want to speak, unmute and speak. If not, then let's go to the answer. So continue to the next page. Okay. So can someone help us read? Please let someone help us read the answers.
The answers we have number one. What? Go ahead.
Okay. What are the red flags in this case? In this case, the only red flag suggesting the need for medical screening was the client's age.
Ajay, that's why you are reading this very quickly. Because you are the one that said age is a red flag, and I said age is not a red flag. So this answer is saying age is a red flag. And I really wonder, because I thought just a risk factor alone will not serve. It will be a yellow flag, exactly. But this is saying a red flag. Is this saying a red flag? Yes, I was thinking really it's going to be a yellow flag. I will go to check.
No problem.
Exactly. I will check and see if age alone can serve as a red flag or whether there was an arrow here putting red, but let's take it as it is. And you have already explained it, and so I agree with you now, but I'm still going to investigate to find out why we have that here. And if it's what it's supposed to be, then maybe on the chat forum or in another class, I will give clarifications. So thank
So
you.
does it mean that any patient that is
Okay,
just
sir.
elderly would just that comes in and complains of pain is already a red flag? I
That's the
doubt
issue.
it. That
I
yeah.
also doubt it because I'm not going to
I really
refer a
don't agree with that
60-year-old
answer.
alone, with age alone, 60 years, just come and say, let me refer. I
No,
really
I
doubt
think
that.
because it involves the lower back actually.
So maybe
Because
some of those symptoms now coupled with the fact that his age is 60 will make it a red flag for me. But just because
Of course,
someone is 60 years old, come to my
it's not a red
clinic, I
flag.
will say, okay, I'm referring you to a physician. You should have a colon cancer. I don't think I will do that. But as I've said, I'm going to investigate this. I will find out no red flag because the patient said a lot of information from the physiotherapist. Well, I think the concept is just that there's something that must indicate there is organic pathology. Age alone cannot indicate that there is an organic pathology. Age alone, because we have people that are 100 years old and they don't have an organic pathology. Maybe they will have movement impairment problems, and they will keep going for physical therapy, physiotherapy, but their age alone does not indicate that they have an organic pathology. Even though red flag does not mean that it's only organic pathology. Red flag may mean that there are issues. For example, if a medical doctor is assessing a patient, his red flag will not be for the organic pathology. It will be a red flag that will help him to be able to refer the patient to a physiotherapist. So red flag can be both for organic pathology or for movement impairment. But whichever way it goes, I would not say age is red flag. Raja, I'm not trying to dispute you, but I think we'll
No,
not.
sir, it's okay.
We'll try
That's
to
why we
find
are
more
here.
information. Exactly. We'll try to find more
Yes,
information. As I've said, this is something
yes,
I
sir.
picked from those books, and I'm going to go back and check whether it was an error, or if it is correct, then what is the justification for that? And I assure you, I will come back and step it down. Yes, so number two.
Okay, sir.
Okay,
Number
someone
two,
wants to
what?
speak? Sorry, before
Okay.
you go to number two.
Yes, sir.
Dr. Taiwo speaking.
Yes, ma. Yes, ma. Go ahead, ma.
I was going to say for me, the red flag for me may not be that I will send him to refer him, but will cause me to ask a few more questions. Being a male, the back pain would have would have set me on the path of thinking, could this man be having a prostate issue that is already sending signal, problems to the back?
Exactly.
Because for me, that age and the gender together, from experience, will always tell me, I have seen so many that I've had to send to the doctor to go and do further examination. They have come for back pain problems, and then in the course of asking questions, because of their age and gender, I've been able to say, and then they come back and say, a lot of other things were revealed. So for age, the back pain and age and gender and age for me would ask me to make further investigations so that we know exactly what we are handling and not just the MSK issue.
Excuse me, Prof.
Thank you, ma. I think I agree. So meaning it's a yellow flag, not a red flag. So I agree strongly. Yes. Uche, yes. Okay, go ahead. Who is it? Is it ST?
Okay.
Okay, go ahead.
Just like you mentioned, sir, I think depending on the condition and the things surrounding the condition, and some are red flags in some conditions. Anyway, hello.
Hello. Yes. Go ahead. Network is
breaking. Go ahead. Go ahead.
It's breaking, but go ahead.
Okay. Yeah. It depends on how you assess the patient, the quality of your assessment, and the things you got from the assessment that will now make you to tag a particular thing as red flag or a yellow flag. Because if we generalize it, you discover that you are seeing something pointing toward a red flag, but because we've already put it under yellow flags, then you say, I can't take this one as serious as a red flag because it's already labeled as yellow flags. So I see it depends on the condition and the quality of your assessment that will now give you the go ahead to tag one particular thing as a red flag with the other things that follows.
Okay. Yes, sure. This is what we are talking about, clinical reasoning. So just have to use our thinking, our thoughts, and the information that we have there to be able to make this decision. So, and different scenarios will give different interpretations. So,
yes, sir, that is the point.
Sorry, was it Uche that was trying to speak together with Uche?
Yes,
You go
I'm
ahead,
sorry.
and then
Yes,
after you, Tom Akin, because Tom has been raising hands earlier. So please quickly, Uche, and then after you, Tom.
Yes, sir. So if I could just quickly look at that assessment, I mean the write-up says I twisted my back, taking out the garbage, and the pain has persisted for 3 weeks, and now the client is in my clinic. So all of this, and then it went further to say there were no further medical screening done. But here, so the age is there. He had mentioned this, we know his age. We knew he had he twisted his back, and then the pain has persisted for 3 weeks. So I think all of that put alone, so I don't know how to put it, but they are saying age. Still not, maybe they are just trying to say the age and the duration of the pain and the way the pain came about, all put together makes it a red flag, because now you're combining both the yellow flag, which is his age, and the duration of the pain and the origin of the pain put together makes it a red flag. So not the age in isolation.
Oh, do you know something I missed? You know something I missed? In the whole of this, it didn't say, it says in this case, the only red flag suggesting the need for medical screening. It didn't say the need for referral. I didn't observe that. So that is what Mama was saying that I did not even notice until now. It says the only red flag suggesting the need for medical screening, meaning it is not saying just because the age. Please, Livinus, Agu or Maka, please, can you help mute yourself? Livinus, or maybe if the admin is there, please, can admin, good. Yes, so please, I think this is okay. It's still the use of the word red was what caused the confusion. But at least the fact that it's saying the need for medical screening, because the physiotherapist is the one that is expected to do the medical screening. The medical doctor is expected to do a medical diagnosis. So I think still we are speaking about the same thing. It's saying there is a need to further screen. But from the concept of what we read on Saturday, a red flag is an emergency that requires referral. And I think that is what caused the confusion. So it could have been the only yellow flag suggesting the need for medical screening. But now I think this is a very clear case that we are not referring someone that is old, 60 years old. We are only screening the systems to see if there is need for that referral. So I think that is okay. Sorry, Tom Akin, please, apology. You have been raising your hand for long. Can you speak before we read the last part of the question? Answer, and then we'll leave.
All right, thank you. Please, can you hear me?
Yes, I can hear you very well.
Right, yes. Still speaking on this issue of red flags, clinical reasoning, and all of that issues put together. But specifically from all that you have said, speaking from the issue of referred pain or referred source of symptoms or signs, I want to say that that is the case instance. I saw a 35-year-old man who has been having low back pain for about 2 years. Activity triggered. So after doing all the exams, physical exams and everything, nothing was, was indicative as to the reasons or the cause of the pains he was having 35 years. So I looked at, and it was really a serious pain that whenever he's walking, it really gives him, problems and all of that. So from the premise of basic medical reasoning, I kind of remember the issue of reproductive, and I kind of asked him if he has fire. As to why I even asked, I can't really, but just occurred to me because I look at his age and everything. I couldn't find any other thing I could, that could possibly be the cause. So when I asked him, do you have pile or something? He said yes. And it's even a bad one that even the surgeons have advised him that they need to operate on. So I was like, okay. So this is possibly and most likely the reason why you're having a problem. So I think using clinical reasoning and also basic medical reasoning will help us, navigate through some of these issues that are very subtle and kind of complex, trying to be in a diagnosis. That's just the contribution I want to make. Thank you.
Okay. Thank you very much, Mr. Tom. Thanks a lot. So Hajia, please, can we just quickly read the last part of the
Second.
answer?
Okay. What other question about symptoms and signs the therapist should have asked to assist with differential diagnosis? The therapist did not ask about any associated sign and symptoms. We must always remember that even with a non-plausible reason for injury, the client may wrongfully attribute symptoms to a logical event or occurrence. The man had been experiencing both abdominal symptoms and referred back pain, but since these episodes did not occur at the same time, he did not see a connection between them. And number 3, what other question the therapist should have asked before finishing the history interview? Always finish every interview with this question. Are you having any other symptoms of any kind anywhere else in your body?
Wonderful. This is a question that I should have discussed last week. I'm very happy that it is our closing statement. Very important, because as I've said, some will think you're a physical therapist. Why should I talk to you about my urination? Why should I talk to you about my heart palpitations? Why should I talk to you about this and that? But if you ask this question, if there is something they have hidden, that may come out because you are asking a very specific question, if there is anything apart from what they have presented. Thank you so much to everyone. Truly, truly appreciate you. When you opened up, you discussed matters. I see the clinical reasoning flowing all through and feel very, very encouraged. I want to ask us to please, this platform, let's maintain it. Anyone that has any case study can post so that we'll discuss it and then we'll get something out of it. I will continue until from now till next week, 2 weeks, because we are still going to have continuation of systems review. Maybe daily, I will just pick the case report of one case, post it, and then ask for discussions. And then after the discussions, I will post the answer. We'll continue to do that until next Wednesday, after the last session of the systems review. Thank you so much to everyone. Is there any comment or question before we close? Okay, I know we are tired. It's almost 11. Dr. Jibril Samani, let me hand over to you.
Thank you, sir. And thank everyone for participation. I think we already have someone that sent the posts to the group for discussion, case study, so that we will start with that.
Okay, that's fine. So maybe you can post it on the group so that we discuss it. I forgot. I should have given some time for us to take that because I promised we were going to do that. Yes. So, but let's discuss it on the platform. Let's discuss it on the platform because it's almost 11 now. Taking a case, I think, might not be feasible. Dr. Fine Achubwe, I think let's give you the floor to speak before we close. Okay, Dr. Fine is no more.
Yes, I am. No,
okay,
I am
okay.
around.
Okay, go ahead.
First and foremost, I want to thank you for, the elaborate exposition of this topic that we have just discussed. I just want to know your mind. If you have drug that is maybe the patient is reacting to a particular drug, and while you are doing your systems review, will it be right to tell the patients to stop the drug while you now make a referral to the patient, to the physician? The question there is it right for the physical therapist to advise the patient to hold on a particular drug that is reacting at, while you are doing your systems review? Thank you.
Thank you. Actually, I will not advise anyone to ask a patient to suspend taking a drug until they see the doctor, unless if the information you have about the side effect and the underlying disease or interaction effects that you think before the patient goes back to the physician, there's going to be a health challenge that way more than what is being treated. If you have that information, then it's an obligation to take that decision. But if the patient can be able to quickly go back to the physician, I would rather the physician themselves ask the patient either to stop it or to change the drug, because they gave the drug to be able to help solve a problem. So unless, because, and side effects are there, what the medical doctor does is to weigh the problem they have that's going to be solved and this side effect that's there. They say, look, both of them are problems, but this one way more than the other one, and therefore let's go with it. So unless you have that level of competence to be able to now weigh and see that the drug and its side effect will give the patient more problem than what the drug is trying to solve, then I wouldn't advise you to stop it. I would rather you quickly refer the patient so that they get there and have it changed or have it stopped. That's just my view of this.
Hello, sir. Sorry, Prof. I don't know if I can quickly add something here. I don't know, maybe it's because of the institution where I work, where we have a more open line of conversation. We can communicate with any consultant at any level in any specialty, so that if I have any type of concern with the patient, instead of sending the patient forth and back or waiting for the next time the patient is able to see the doctor, is it possible that I ask the patient to either I get a feedback later in the day or immediately put a call up first to a professional, because if we're in the same institution, then it's easier, I guess, to be able to reach out, because the interest of the patient is at stake, and so that we don't do harm to the patient on both ends. So that for me would also be, I do it. I call my consultant, no matter who it is, and I say, we have this patient, we've been asked to do this, and we think this might need to be reviewed. What do you do? And the consultant say, okay, ask them to see me, let them get an appointment to see me, or let them, something like that. That's just for me, and that's it too. So there has to really be a big collaboration to have that kind of decision.
Thank you. I think I mentioned on Saturday that there are about 4 decisions that you can take after your assessments and evaluations. Either you keep the patient because the only thing established is a physical diagnosis, or you refer the patient because the only thing established is an organic pathology, or you keep and refer at the same time, meaning you have a physical diagnosis but you suspect an organic pathology at the same time. So you are keeping the patient, seeing him for the physical diagnosis, and you are referring at the same time so that they get solutions to the organic pathology. That's number 3. Number 4 is consultation. And what you have just talked about is consultation. And I appreciate that. It's very important. It is part of the multidisciplinary or interdisciplinary or transdisciplinary approach to medical care or healthcare that is very common in the practice. So thank you so much. These are really very wonderful, very brilliant discussions raised by all of you. I thank you. I just pray that what we have here, we'll take it to our clinics and then we'll continue to advance. The textbook is there. Continue to study it. I will send all these documents that we used today and others that we have not touched on, and then I will continue to make posts and we'll discuss so that we'll continue to get more insight into this area of systems review and things like that. Thank you so much, everyone. Dr. Samani, over to you.
Okay, thank you all. Hoping to see you Saturday. Bye bye.
All right, thank you. Good night.
Good night, all. Thank you.
Good night. Thank you, Prof.